So in this final segment, and again, I think we've all talked about this, multiple publications, multiple discussion points about now these patients that progress to true metastatic castration-resistant prostate cancer. So Phil, is there any role at all in some of these newer biomolecular imaging agents?
Currently, I would not recommend any of these next generation imaging tools in the M1 CRPC space for patients undergoing therapy. For those patients, it makes sense to stick with the tried and true bone scans and CTs that I think really need to be tailored based on the type of therapy they're receiving and how they're presenting. And again, you guys are much better experts on the triggers to image. That being said, I think there are some specific scenarios where we need to be cognizant of how to image and interpret it carefully, because clearly we know that flare can occur. So radium-223 is a good example of patients who undergo 6 cycles of therapy. And I think the St. Gallen recommendations actually don't recommend bone scanning after your 3rd dose, which a lot of people do, because a lot of times that can be misinterpreted as progression when it is a flare. So I think we need to be careful, but we should stick to the tried and true CTs and bone scans.
So we know that the current landscape of therapy includes immunotherapy, traditional taxanes, androgen receptor signaling inhibitors, and androgen synthesis inhibitors, alpha-emitting agents. We know that one of the big unmet needs is really the ability to monitor these patients' progression relative to biomolecular markers, liquid biopsy, those types of things. Dan, lots of talk on PARP inhibitors, those types of things. What other agents do you foresee over the next couple of years that are going to be coming to the forefront?
Yeah, Raoul, I think this is a great kind of opportunity for us to kind of introduce the idea of genetic profiling in this population. And the PARP inhibitors give us a really good initial reason to do that. And so the strategy goes like this. There's about, in the metastatic setting of patients, so this is not for primary prostate cancers, but for cancers that are really stage 4, that have gone into sort of the lethal phenotype. For those patients, we see about 20%, 25% of tumors will have somatic changes in DNA damage repair pathways. And BRCA2 and BRCA1 are sort of the most well recognized, but there's ATM, there's CHEK2, there's Fanconi's anemia. There's a number of these genes that play a key role in DNA damage repair that are going to make the tumors susceptible to PARP inhibitors, which are really inhibiting the sort of single-strand repair. So you have the homologous double-stranded repair pathways knocked out. You're really dependent on that single-strand repair mechanism. And when you block that with PARP, they're particularly sensitive to this. So that strategy is working even as single agents. And what's nice is the opportunity to potentially combine those with other strategies in the future. And we're starting to see that with immunotherapy and other things. So for us to be able to treat patients like that, we have to know. And the best way to know is if we can biopsy that metastatic disease and then profile it. Now, sometimes that's not amenable. The biopsies are hard to get, the bone is hard to biopsy. So we'll do things like circulating tumor DNA, which can also be a hint to this. And some of the PARP inhibitors are being developed with companion diagnostics specifically for that purpose. And then there's one other approach, and that's to look at the germline. So in patients, and we do this even in older patients. So we think historically, patients really young with prostate cancer, we should look for germline changes. It's important to recognize these changes that we're looking for are associated with lethal disease, not necessarily associated with the incidence of disease. So the genes that are associated with prostate cancer incidence are different than the genes that are associated with prostate cancer progression and lethality. So that's why we think about this germline testing in the metastatic setting, not necessarily in sort of upfront patients with family histories of prostate cancer, but no lethal disease. So it's that kind of context, and it doesn't have to be a prostate cancer family history. It could be ovarian cancer. It could be any sets of multiple cancers, because what we'll find are sometimes things like Lynch syndrome and other things that predispose to other therapies like immunotherapy. So not all of this is simply for PARP, but PARP is the most common one, and it gives us the opportunity to kind of frame to the patient how these profiling can be actionable. And just like Phil said about, you want to do the imaging if you're going to act on it. We want to do this if this is a patient that we would actually treat, and if they have that genetic predisposition. Germline is not as frequent, but it's still almost 8 to 10%.
Right.
So if you send enough, you're going to find them.